Yep. Hey, Lisa. Lisa. Yep. I'm waiting. So I think maybe I'll pause. Yeah. Maybe. Oh, there's like 6 minutes. Hello. Hello. Hi.
There it is. Hello, can you hear me?
Yeah, I can. Can you hear me?
Let me turn you up somehow.
I was going to do a phone. I went back over my notes. I'm sorry, Steve. I'm Jill.
Hi, Jill. How you doing?
Good. Good. How about you?
Is this your office with the Golden Gate Bridge in the back?
I can't figure out how to get rid of it right now. If I mess
How would
with
you
the
want to? It
settings,
looks great.
right? But
Yeah.
you can see like this is like a bathrobe and.
Yeah, I won't tell anybody.
Okay. Okay. All right. Yeah. So thanks for doing this. I was gonna call you on the phone, but because I was reading back over the notes and it looked like you wanted a phone call, but then I did the Zoom meeting, so appreciated.
All right. I just pulled it up on my calendar and then panicked a little bit when it didn't load up properly to begin with. I'm just looking for my questions that you had.
Yeah, take your time.
Sorry, just a second. This has to do with Nicky's Garden of Hope.
Yeah, kind of. I just basically want to get your experience as president of a hospital, particularly some of the programs that you have been involved with and started. And, the efficiency aspects, just personally, I've had like these really challenging situations with a major hospital.
Well, we're not a major hospital. We're a small hospital. But
I know. Well, I guess I want to hear about it. I want to hear about your process and whatnot. So
sort of annoying.
If you can't find them, I can resend them.
Well, I can pretty much.
You can probably wing it.
Yeah, I do okay with that. It's just good to work off of something. All right, I can't find it. All right, so there was a question about my background. My background is I'm on my third career. My first career was in IT. I worked for IBM. I worked for Control Data, and then I was an entrepreneur in the IT field. That was my first career, and I worked as an integrator, integrating computer systems and application software and implementation, modification, training, all those kinds of things to develop solutions for customers around accounting, financial, manufacturing, and different types of vertical markets like that.
Okay.
Manufacturing, construction, development. So I was very, very involved in really in industry doing that kind of work.
Okay.
Outdoor data collection systems, all kinds of cool stuff. And then I went back to school and retooled and for healthcare, and I wasn't able to get a job at first in healthcare because I didn't have any experience.
Uh-huh. What made you go back and go back to school or whatnot to do that?
Well, I was really quite successful doing what I was doing in IT.
Uh-huh.
And I visited my 90-some-year-old grandfather, and I was telling him how successful I was, how I had really nice clothes, and I wore suspenders, and I had a new car, and I took great vacations. I owned a house before I was 25. I did kind of the world by the tail. But my grandfather was a farmer and a Presbyterian minister, and any money that he ever made, he gave away.
Uh-huh.
Because he thought other people needed it more. And all of my efforts to impress him all they did is turned him off.
Really?
Finally, he said to me, he said, well, Steve, I'm very disappointed in you, but I have great faith in God. And maybe your children or your grandchildren will amount to something.
Wow. Yeah.
So at first I was very angry and insulted, and I was in my late 20s by then. And then he passed away, and it grated on me, and I decided to change careers. My mother was a nurse, so I went back to school. I got an MBA in health systems management, MBA in health, and I went on to I went into research after that. I worked at Rensselaer Polytechnic Institute as a research scientist, and helped to develop the reimbursement system for nursing homes called RUGS, which is Resource Utilization Groups. So we did a study in nursing homes, in 85 nursing homes, and we had a clinical assessment of the residents who lived there, and then we did a resource consumption, which means cost. So we did time studies of everybody that spent time with the residents and how much everything cost. And then there were statisticians that put those two data sets together and figured out what were the clinical conditions that predicted cost and modeled them and stratified them. And that became the reimbursement system that's been in place for probably 25 years.
Huh. Wow.
And then some folks from the health department liked me, and they tapped me to be the principal investigator, which is a whole lot better than being a grunt research scientist.
Yeah. Yeah, moving up.
To do a similar project around emergency department visits.
Okay.
And I worked on that for 3 years, and it was very cool. But then we had a change in the governor's mansion, and the new governor felt about everything that the old governor did, pretty much like the current president feels about everything that the old president did.
Okay, so a real like.
So my research was truncated, and it never got finished. But I learned an awful lot about ERs, and I always promised myself if I ever got the chance, I would fix it.
Huh.
So I decided I was a little discouraged because, my children had gotten used to eating every day and things like that. So I had to get a different job. So I decided to go into something more reliable than grant-funded research.
Okay.
I decided I would go into healthcare administration, only to discover that that's not very safe either.
So you jumped from the research into the administration. Now, how did you have to go back and get more training for that or education, or were you able to just?
I called up the CEO of a hospital and convinced him to create a job for me.
Did you?
Yep. So he sold half of my time to a group of doctors that owned a surgical center.
Okay.
That needed an administrator. And then I reported to him and I did special projects for him in the other half of the time. So one of the projects that I worked on was representing Kingston Hospital, my employer, in bankruptcy court for another hospital, Ellenville Hospital, where we had loaned them resources that they never paid for, and so they owed us $379,000 or something like that. And I represented Kingston in bankruptcy court and became the chairman of the creditors committee and sold the hospital to Westchester. And no good deed goes unpunished. And so a few years later, when Westchester was looking for someone to blame when the hospital closed, they entered into a management agreement with Kingston, who sent me down here to be the CEO, and I'm still here.
Oh, wow.
So
Okay.
the hospital was on the verge of closure. It was failing by every account, quality, finances, facilities, by every metric, the place was closing. And we were able to come up with a harebrained scheme, and we didn't close, we survived. And now, 15, 16 years later, we are really a top hospital or rural hospital in the country. We speak often around the country on different topics like quality and clinical outcomes and innovation and IT. So we've done really well in a lot of things. We have a lot of education. Every department in the hospital has an education component, so we train nurses and nurse practitioners, which are now doctors. We train physical therapists who are doctors, pharmacists who are doctors, occupational therapists, which aren't doctors yet. We train rad techs of every flavor. We train lab techs. We train high school kids. So we have
incredible
coming in the bottom, and we do all that with no money.
No, okay, so
we train physicians as well. We have residents that rotate through here. So my hero was Rumpelstiltskin, because he could spin straw into gold.
Well, geez, it sounds like you're doing a pretty good job of it.
And we're profitable. So we last week I was in Niagara Falls speaking at the state Rural Health Association's annual meeting. The week before that, I was in Kansas City speaking at the National Rural Health Associations. They have 2 annual conferences. I spoke at their earlier one in May, I think.
Okay.
Or June. I think it was May, because they do one twice a year. So, and then I'm speaking at the World Rural Health Association meeting in next month, in middle of, I think, like the 13th or 14th of October.
Wow.
So last year I spoke at 10 major conferences. I spoke in Austin, I spoke in Boston, I spoke in North Dakota, Minnesota, Manhattan, White Plains, Syracuse. That's not 10, so I don't know where else I spoke. But
that's great. What kind of what are your speeches involving? Are you trying to facilitate these other hospitals to implement some of the programs that you've been successful implementing at Ellenville, or?
Yes, I speak a lot about fighting the opioid epidemic.
Okay.
The opioid epidemic is a pretty big problem. It's the largest public health problem that we face. It's killed 700,000 Americans. And when you put that in perspective, when I was growing up, we had the Vietnam War, the last war where we lost a lot of people, and we lost 54,000 people. And we lose quite a bit more than that every year.
So how did you put a program, or what does that look like in brief?
So in brief, what that is we developed a plan to reduce opioid administration in our emergency department. And the reason we did that is that the way that people die from opioids is most of them don't die from prescription drugs. Almost all of them die from heroin or fentanyl, or a combination of heroin and fentanyl and sometimes other drugs.
They get hooked, and then they seek out they get pain meds, and then they can't get them, and they, because they become dependent, and then they seek out street drugs. And
80% of the people start out on prescriptions,
Right.
and they migrate. Whether some of those are diverted, some kids are taking them for kicks. It isn't all prescription. But I mean, now when people rob houses, they don't go for the jewelry box; they go for the medicine cabinet.
Yes.
That's the easiest thing for them to sell that there is. So and we've overprescribed, so people have lots of this stuff laying around, and it gets diverted and it gets used up. And so then once now we've cracked down on that, and a lot of people have switched over to heroin, which is cheaper anyway. And now there was fentanyl coming in from overseas in packages. We're just flooded, and it's about 50 to 100 times more powerful than heroin. So even a little bit of calibration error puts people into respiratory arrest. They stop breathing, and then they die. And if somebody finds them, it doesn't happen quickly. It isn't like sudden. It takes a couple of hours, but it gets really great high as they slide into death. And if somebody finds them, they can use Narcan, this mist that's a reverse aid, spray that up their nose, and it wakes them up and puts them into withdrawal. So they're really unhappy usually when that happens, because they were having this great ride just before they died, and somebody
Brings them
Narcan
back
to life. So we've been doing this for about 5 years before the magnitude of the epidemic was known. So we put together a plan with our providers in the ER to substantially reduce narcotic administration in the department.
Okay.
We reduced it, really looking at chronic pain patients, because it's a fine line between treating pain and enabling addiction. Somebody comes in, they say, my back hurts 12 on a scale of 1 to 10. The only thing that works is IV Dilaudid. Push it really fast, because that's how it works, the back. And so then we do these big expensive workups with CAT scans. They'll be radiated. You could draw gallons of blood out, looking for some reason to give them what they want. And in the old days, we just gave it to them.
Yeah.
So we don't do that now. We refer them into treatment with a primary care doctor, who may send them to an interventionalist, because if it's a back problem, they're probably a lot better off getting shots to go and reduce the inflammation and reduce the pain at its source, rather than medically, systemically.
Right. So taking a step back and looking a little bit beneath the superficial presentation of the problem.
And looking at ways to treat their addiction. And so now our latest, that's what we've been doing. And then this year we started a new program for people that have overdosed. Can you close my door? Ahmed, can you close my door, please? Then we started a new program this year, where we had all of our ER providers trained to administer buprenorphine, which is the medication that people use that takes away the withdrawal but does not make them high. So when they
Suboxone, is that the
same
the
stuff?
name? Yeah.
For name, Suboxone, buprenorphine. I believe that they're basically the same thing. And so we do that, and we have partners who have, part of the problem is there's not enough people who are waivered to be able to do this long term. We do it for up to 3 days in our emergency department, and we have partners, Catholic Charities, Institute for Family Health, Step One, providers who agree to take every patient that we refer to them.
That's beautiful.
And so we have peer counselors that come to the ER. So somebody gets Narcan back to life by the police, by the rescue squad, by their family, and they get brought to the ER. We have a peer counselor come in to talk to them about, you just narrowly avoided death.
Yeah.
You feel terrible because you are in withdrawal. And maybe they have children, but everyone has a mother. And would your mother want you to die of an overdose and be gone? This is the time we think there's a teaching moment where we might be able to convince them to we dangle the buprenorphine in front of them. Here it is, the withdrawal goes away. And I would like to tell you that it worked every time, but it really doesn't.
Well, there's no magic bullet, I think, but that's a really comprehensive solution, because you're thinking of a lot of different angles of it, not just, fixing them, giving them something and sending them on their way, but kind of meeting them there and integrating with other programs and like giving them the support they need to actually maybe grab on. And I know for some it's probably
the thing about addiction is, especially opioid addiction, is it is different than other diseases. We're used to physical diseases. If somebody comes in and we do a CAT scan and we find out that they have cancer.
Yep.
And the doctor says, you know, I think you have cancer. I see a tumor here. Then the patient is immediately wants to know, what are my options to either have chemotherapy to shrink it, radiation to shrink it, surgery to cut it out. In what order do you have those depends on, you know, the kind of cancer that you have. And it's all about fighting the cancer. When you tell somebody you are addicted to heroin, they're not really interested necessarily in changing. In fact,
Right.
Unless the peer counselor is able to counsel them enough, almost every time they're not really interested. All they want is another fix, and they want you to stop telling me what to do. And the reason for that, or part of the reason for that, is that heroin changes the chemistry of people's brains, or opiates, not necessarily heroin. And so that changes everything, and they're not able to think like they would if they weren't addicted. It overpowers them and eventually kills them. So it's, a lot of people cope for a long, long time, many years.
Yeah.
Many, many years. So that's the kind of stuff that we're working on here.
Yeah.
We've got educational programs. We speak a lot about opioids because we've been at the front end. Other hospitals have adopted our protocols.
Have they?
We speak, other topics that we speak on are change management, because most of the time it's very hard to get change, especially in healthcare, where people grow up through the hospital system or the healthcare system. This is the way we do it. This is the way we've always done it. If there was a better way, we would be doing it that way. That's why we do it this way.
Yep.
And they're not really that open to entertaining change or other ways to do things. So that's.
How do you do that? How do you approach that?
Well, I come out of technology where change is like, think about it. We used to have computers the
Yeah.
size of my hospital, and now they're the size of a wristwatch. So
Right.
This is, and if it was a car, it would go 1,000 miles an hour. It would be faster than the fastest fighter jet.
Right.
You know, I mean, that's what we're talking about. It's just, and so I just see things differently. I didn't grow up through healthcare, and so I didn't know that this is the only way to do it, and this is the best way and the only way. And so I always ask, why do we do it that way? And I'm frustrated when people can't really give me a very good answer. I'll give you an example.
Yeah, please.
An example is when I finally got my hospital, when I became the CEO of a hospital, one of the things that I wanted to work on was fixing the ER, because I always said that if I got the chance, I would fix it. So I applied. I went and I measured how long it took for us to get patients through. It was about 3.5 hours, which was actually better than the 4 hours and 7 minutes national average. And everybody thought that was wonderful. And I thought that was terrible. And so we started, I asked the staff to get people through faster. And they couldn't understand why I would want to do that anyway. And what I had learned is that the longer a patient is in the emergency department, the more agitated they get.
Oh, yeah.
They're really worried. They think that they have something that is going to kill them. They think they're going to die. This is something that they've never seen before. It feels different than it ever did. It's got to be cancer. It's got to be heart disease. It's got to be Ebola. It's got to be something that's going to kill me. And then when they get the diagnosis and there's a treatment plan, once they know what it is, then they can deal with it. It's not going to kill me. I'm going to be okay almost all the time. And I have a treatment plan that will get me back to where I was. And then all that pressure is gone.
Yeah.
Completely relieved, and they don't even know why they yelled at the nurses over and over when they had to wait. So the sweet spot is about an hour and a half. If you can get people in an hour and a half and have all that done.
So Steve, did you do analysis of the time that to get to that hour and a half? How did you figure that out?
Well, we did interval analysis of all the intervals of an ER visit. So in the old days, somebody would come in and we would have a seat in the waiting room, and the waiting room would be packed because we were pretty slow relatively speaking.
Mm-hmm.
And they would wait, and then we bring them in for triage, which is an initial assessment.
Yep.
That takes 3 or 4 minutes. And then we would send them back to the waiting room to wait
Yep.
some more. And then we would bring them up to the
Yep.
registration window to get them registered. And then we would send them back to the waiting room to wait some more. And when a bed became available, we put them in a bed and they would wait for the
Yeah.
nursing assessment. And then they would wait for the provider to come and do his or her assessment. And then the provider would probably have a pretty good idea of what it was, but they order tests to confirm it. So then they would wait. For the lab test to come back.
Yep.
First, somebody to draw the specimen, and then for the lab to run it, and then for the provider to get the result, and then to get back to them and to tell them, I'm going to have to order an x-ray because it wasn't what I thought it was, and ask them other questions, or I got it, this is what's wrong with you, and here's your treatment plan. Have a nice life. And then they could go through, the nurses would actually take them through the treatment plan and get them discharged and all that process. Today, that takes 100 minutes, door to door. And
That's amazing.
90 minutes to get to the diagnosis, 92, 93. And we did that by looking at all those intervals and trying to squeeze all the waiting time out.
How
now
did
somebody comes in, they have triage immediately,
Okay.
and if possible, in the bed with the nurse, and at the same time, then registration runs over with a cart and registers them in the bed, at the bedside. The provider may interrupt that to do his or her assessment and get the process started. Then they finish registration, and then at the same time, somebody's drawing the blood out of them. Meanwhile, down in the lab, which used to take an hour and 15 minutes, I went down and I talked to them. I said, we measured this, an hour and 15 minutes, which I find out is pretty standard. That's about what people expect it should take. I was told, yeah, it's fine. I said, well, how long does the chemistry take? What's the process? They said, we don't do anything here that takes more than a half an hour. I said, these are emergencies. I want those results upstairs immediately. And now it takes about 21 minutes. Depending on the
I love it.
19 to 23. So we're measuring that all the time. And so that's what we do. And this isn't like our best week or our best month, or even our best year. I've done this for 12 consecutive years. And our community, this is the strange thing, our community noticed.
Did they?
So today we see twice as many people in about 40% of the time with the same staff and a lot less aggravation for everybody.
And how receptive was, how did you sell it to the staff and the supporting people in the ER?
Oh, it was really easy. The nurses came to me when I said, we need to get patients through faster. They said, my mother was a nurse, my grandmother was a nurse.
Okay.
They said, we'll get this done for you, but we're going to need a lot more nurses. And I said, why will we need more nurses? It's going to be less work. They said, how can it be less work to get people through faster? That's counterintuitive. I said, well, last I heard, you're responsible for the patient the whole time they're here. If they're here half as long, it's half as much work. We need less nurses. I didn't buy that at all. But
yeah.
And so, in fact, that turned out to be true, and a lot less aggravation. And once we started measuring these intervals, people got on board with it, because now it's sort of, I don't want to say a race, but they realized that there was all this unnecessary time. And if they could figure out how to make their procedures move quicker and cut out things that they didn't need to do, and also I talked to the providers. I measured the providers. Some of our providers were able to see the patient in 15, 20 minutes. Other ones were maybe 30 minutes. We had one guy, who will remain nameless, who took well over an hour. So I went to see him.
To mosey down there and make his analysis.
Well, I went down, I showed him the data. I said, let me show you this data. I need some help. I'm trying to understand this. I said, we got this provider who's there in 15 minutes. This one's in 19 minutes. This one's in 22 minutes. This one is in 31 minutes. And here's you at 96 minutes or whatever it was. And he said, Mr. Kelley, I can explain that very easy. Very, very easy. What it is that patients appreciate how important you are and how well skilled you are if they have to wait a little while. So I got it. I said, got it. I understand now. And that was the last day that he worked with us.
So it was a power
now,
trip.
That same metric is running around 9 minutes. So when I hear of all these places that say, you'll be seen in 30 minutes, I wonder, why would anybody want to wait another 20 minutes?
Yeah. Yeah, as you're telling me this, I have kids that have issues and have been in and out of ERs a lot, and it's for parents, it's just so exhausting. It's exhausting for everybody, but just
Yes.
that waiting and not knowing these unknowns, you're like, well, why? Why is this happening? Why does it take, the more you go there, the more you start to question, like, why is this person, what is going on,
Most people are pretty good for an hour and a half, and in most places they haven't even left the waiting room yet.
Yeah, yeah. Wow, that's
I
really
haven't
impressive.
gotten through the waiting room yet, and I'm getting people finished with their treatment.
Yep. That's
I get
that
people, I have healthcare on demand, 24/7, 365, faster than most scheduled doctor's appointments.
that's great. Great. And it seems like you've kind of like made it a collaborative effort. I love that word, with the way you have treatment plans. Now, how did you get community involvement and like the collaboration from community programs or whatnot? Can you speak to that?
From the police, the rescue squad, the local federally qualified healthcare center, other doctors, the county executive, all those folks. I'm just lucky.
Yeah. So, okay, so the ER efficiency, and tell me a little bit about the database or the electronic medical records.
That we've been a development partner with a company called Athena Health, which is developing a new electronic health record system for hospitals. They've been are in the physician space for electronic health records for a long time, and one of the leaders in that area. And so we became a development partner for them. So all of their alphas for new products start pretty much with us. And then they go to a beta phase where they turn on other hospitals to stress the product with transactions once they get it working with us. And then it 3 times a year becomes a general release, and then all the other hospitals get it. So I talk about that because when you're doing technology, that kind of thing, it's just kind of cool. We get to put our fingerprints on the future, and
Yeah.
it's a fun thing. So I really like doing that, and so my people have to put up with the aggravations of having things that don't always work exactly right the first time through.
Well,
But the other side of it is the engineers talk to them and about what they really need and why they need it and how this works, and try this, try that. And so many of the things that we've suggested have become part of the product. So
wow.
that's kind of cool. So that's what we're doing in that area. I talked about opioids, I talked about efficiency, I talked about education.
Challenges, as you see it, with the changing landscape of healthcare and the role of hospitals. It sounds like, I wrote down, how do you plan to prepare and adapt, but you've kind of gone over that. Kind of give me a broader view of how you see the role of your hospital and as things change, with possibly single payer.
I don't see single payer winning because the insurance lobby is very powerful, and I don't see that happening. I also am not sure. Well, I see it, in theory, I think it's probably the best thing, because we have to spend a lot of money managing all these different programs, where if you have Medicare, we know that Medicare does not cover vasectomy. So if somebody wants to have a vasectomy, they're going to pay for that themselves.
Really?
That wouldn't apply to you, obviously, but that I'm just using that as a known example. So if you have some older gentleman who suddenly has a younger love interest and doesn't want any more children and wants to be sure of that, then you have a vasectomy. This is common practice.
Yeah.
But they get to pay for that themselves, because that's not a covered service.
Okay.
And so it's very easy to know what's covered and what isn't covered, because it's only one plan, and it's a pretty big plan. And while that's not a very common thing, I used to run a surgery center where it was more common. And that was things that, you know, I was always surprised, not always, but once I learned that that was not a covered item, it's one of the things I always think of, because I'll never forget that. Maybe someday it'll be covered. So if you go to a single plan, it would be easier to administer and therefore less costly. And I wouldn't need as many people to do billing because it would be a lot less complicated.
Yeah.
And in theory, you wouldn't need to have as many codes, and it would come up with a less complicated way to actually do the billing instead of ICD-10 codes, which there's 83,000 codes. So they're counting the hairs between the knuckle of the last knuckle and the beginning of your fingernail. And if it's on the left side and or back, that's a different code than if it's on the right side and it's, you know what I'm saying? So it's like,
yeah, I do. It's
so
maddening.
the amount of cost to document that, because if you don't document it right, you don't get paid. And if you don't document it right, it can't be coded properly. And if it isn't coded properly, you don't get paid. And the reality is, I'm not sure that we should be at that level because it isn't really for clinical practice. It's to get paid.
Yes.
Why is it that it's that way, so complicated? It is that way so that we can't get paid. It's that way. I think it's that way so that payment can be denied. So that part would be better. On the other side,
Really, you think that?
well, let me finish. I think that it could be. I don't trust the government to make it better. And I think that everything gets more and more complicated and more complex. And anything that the government does not necessarily become simpler and easier and cheaper. And so it would, I don't know first how it would get paid for. Nobody knows that.
Right.
Right now we have a fragmented system that's paid for in different ways. And we have another thing about a single payer, I think it would be more fair. Right now, if we have somebody who's poor, is covered by Medicaid, they're covered by Medicaid until they become 65, and at which time they become now more important because we get paid more by Medicare for the exact same care that we're providing. So we value old people more than poor people. And now we're going to take all the working people who are in private insurance, which we've been able to cost shift the losses of Medicaid and in many cases the losses of Medicare to the private sector. So now we're saying the private sector is not going to have to make up that loss.
Mm-hmm.
So who's going to make up that loss? And there's huge costs here. I think that is not a good thing to do because it's so unpredictable and will completely destabilize the system with inadequate payment and continuing complexity of how to get paid.
Yeah. Yeah. It can't be like something that happened. There needs to be like in my opinion, there needs to be a process to get from point A to a better system. Because yeah, it will destabilize. You can't start one thing and end another that quickly. I mean, we're talking massive amounts of people across the country. So I get that.
Million people.
Yeah.
I don't think it'll happen because I think it's just so unpredictable. What happens is if things go bad, then elected officials don't get reelected and they can't do all the good works for the people.
Ah, I see.
So I think it's just too dangerous for them to really make a gigantic, huge shift.
Yeah.
You know, it makes great rhetoric to run for office. The practicality of it is I think is not really very easy to.
Yeah.
Things. I mean, if you were running for office, chicken in every pot.
Right.
But could you really implement that?
I know. Well, yeah. I mean, just total layperson thinking of the complexities of doing that is mind-blowing. But you're right. It does set up, it's a system now that marginalizes people in ways that are also really frustrating.
It really is. And it also is an unfair system. We treat, as I say, we value working people more than old people and old people more than poor people. And is that necessarily right? We'll always have people at the upper end who will pay for their own health care or their own everything. So we're not as worried about that, small percentage.
Right.
People aren't in that. We have a lot of poor people in our country and a lot of middle-class people, hardworking, regular folks who need health care. Their children need education. And And this is like part of the problem with rural areas. It costs
Okay.
more to educate kids in rural areas because you've got all the transportation issues.
Hmm.
And healthcare is more expensive in rural areas because we don't have the volume to spread
Okay.
transactions over. So if I had an MRI in a rural area like I do, I'm not able to generate as much volume as I would in an urban area where there's a lot more people getting MRIs. So therefore, the cost per MRI really is more because I
Hmm.
can't spread the cost over as many transactions. And so what we hear often is, well, we're paying too much in rural areas, and so we should cut that. And I would say, well, maybe we should cut education also and only educate people to the 6th grade in rural areas because it's more expensive. I mean, it's the same argument.
Yeah, I get you. Yeah. People aren't thinking through the whole part of it. Yeah.
It makes no sense at all. Of course, it's going to be a little more expensive for things where you have low volume hospitals and low volume communities. And it isn't right that people should have to travel hours for education or for healthcare. It just
True.
isn't right. We should be able to provide that in a civilized country.
Yeah.
So I'm
Yeah.
involved in policy issues.
Okay.
We have our congressman visiting us on Monday. We have, I speak a lot at conferences and those are areas that I talk about because we need to figure out how to be efficient anyway, and we need to figure out how we can be successful and profitable. Because if you're unprofitable, then your quality will eventually erode. When your quality goes down, then your outcomes deteriorate. Remarkably, people with bad outcomes aren't very happy, and then your financial performance suffers. Conversely, when you're very innovative and you improve your quality, then your outcomes go up and you get sued less and you have really high, actually have high patient satisfaction, you get sued less and you make more money.
Yeah.
It's not that hard.
Right. No, it's not. It's logical. It's so what kind of policy are you talking about here? Not to get
Probably
too
more
segue.
technical than there are more technical things to find ways to keep business in rural areas that can be done in rural areas. So we're
Okay.
a primary hospital, so we do a lot of rehabilitation. We support the primary care and specialty doctors that can do outpatient surgery. Most surgery now is outpatient. People shouldn't have to travel for outpatient surgery. They should be able to get that locally.
Great.
So we should have incentives to make sure that that happens so that people aren't traveling long distance to high-powered medical centers that have very high capital outlays on electrophysiology labs so they can burn holes in your heart to kill the part of your heart that's making your heart beat irregularly so it doesn't pump the blood properly.
Oh boy.
I mean, that's high-tech stuff.
Yeah.
That should be done in a major medical center. It shouldn't be done out in the country.
Yeah.
However, there's all kinds of other things like putting in pacemakers that can be done safely in an outpatient setting. The patient go home that day. Most orthopedic surgery is outpatient today. So figure out how to make sure that business in rural areas stays there.
Okay.
And we can't get that unless we have innovation, quality, high outcomes, and high patient satisfaction. So we need to be able to have best practices to help facilities to do that. And so I talk about that kind of stuff and try to get policies that support that.
That's great. Really, really a lot of excellent, and yeah, I'm impressed to hear this.
Come around to Nicky's garden.
Yeah.
That is sort of what you wanted to talk about.
Yes, it is. Well, I did want to get all this information. It's helpful for everybody that deals with hospitals on a regular basis. And a lot of the people that listen to the podcast do that. So it's helpful.
Okay.
Yeah.
So what do you do with this? So you're going to be able to take some snippets out of this and edit it down, hopefully?
Yeah. Yeah, we will.
I did a lot of talking here.
No, it's been great. And we'll use portions of it and put it together into, I don't know how long it'll be, but you'll be able to listen to it before it goes into any kind of public.
This isn't really about me, though. This is about Nicky's garden. So
it's about learning from you and what you bring to Nicky's garden. Into I'm fascinated with people in general. So it's kind of like both. to understand the hospital. I think understanding the process of a successful small regional hospital is really fascinating for lots of people, I think.
So I'm an entrepreneur. I can think of myself as an entrepreneur. I've owned
Okay.
businesses before, and so now, thanks to my grandfather, I use my entrepreneurial
Mojo?
expertise, mojo, whatever,
Yeah.
in a not-for-profit sector. I work for a board of trustees who hire me to run their hospital for them. And so I think of myself as an entrepreneur. I do have bosses, but they've been very generous to give me a lot of freedom to try stuff. And I wouldn't tell you that everything works, because nobody, that's just not true.
Right.
But we're small enough so that if it doesn't work, we can stop doing it before it does any
I
damage.
see.
And we can try to do something different to steer ourselves onto a better course.
Okay.
So Nicky's Garden, I do a lot of work with folks who are interested in doing projects, economic development.
Okay.
And the county economic development officer suggested that they talk to me, because they were talking about doing this project. And so I work with people, quite a bit actually, who are interested in that, because I'm an entrepreneur. I'm interested in startups. I'm interested in interesting things. I'm interested in
New things, progress.
Trying to figure out how to do things better. And when I met with Adriana and company, and Chris and the whole team, I was captivated with, this is a real problem. Autism is a growing problem, and nobody really understands why we have all this autism. And it's been growing really exponentially. I got that pronunciation wrong, but exponentially over the last maybe 30 or 40 years. It's always been there, but it never was at the rate that it is now. And as it has become apparent, we've had parents who have been able to advocate and get the laws changed so that their children are cared for through the school system. So they get all kinds of services. It varies from district to district, but progressive districts have a lot of services for children with autism. And then when they are no longer eligible for public schools, which I think is 21 or somewhere around there.
22.
Okay, again, this is not my area of expertise.
No, I know. It is. I do know a little bit about this area, but
22 it is. I'm not arguing with you.
No, I know.
And at some point, they reach the end of the resources.
Right.
And then there are no more resources.
Right. Well, there are resources. They're just a lot of them are income dependent, and they're very siloed. They're all over the place, and they don't collaborate at all.
And you are right. There are agencies that do care for autistic people.
It's tough, though.
It is tough. And I think that I just like their model. I thought that the idea of having a more integrated program instead, and I've done volunteer work. I'm sit on a lot of boards, and have sat on a lot of boards, and one of them was an agency that provides mental care to people with mental illness.
Okay. And
they had a sheltered workshop, and they had a residential component, and autism and mental illness aren't that far apart.
Nope.
It's somewhat of a different population, but I think that the concept was really good. I really like the idea of people being able to contribute as much as they can towards their own well-being.
Absolutely.
And then we in society have to figure out how to make up the rest. And so the Nicky's Gardens approach is to give people the dignity from that 4-letter word of work to contribute to their own well-being as much as they can, and to have programs to kind of help them the rest of the way. And to have that in a very supportive environment, and to have a residential component where they would be able to live and also have many of the workers, the counselors and so forth, be able to live on that campus, and the parents, because in many cases, the parents need to have some space so that they are able to live comfortably and have their life back a little bit, because it is so difficult to care for such a needy population, even though they're your children. So this would give them respite, and in many cases, they would be able to live on the campus or nearby and participate to the extent that was practical in their children's lives without having it be completely consuming to them.
Or, yep, or cut off. I think some
Or
parents
cut off,
just,
that's the other side. You're right. If they put into an institution where they're not able to be engaged with their kids. So I see the whole role of family on multiple levels as being very, very appealing. And I think that this won't appeal to everybody. Nothing does.
right,
But I think that there are a lot of parents in the metropolitan area who really want to have their kids have the best care and be able to participate in it and know that the kids are now young adults and then eventually they'll grow up, will have a good long-term solution that includes activities that are productive and provide a feeling of importance and value, as
yeah,
opposed to not having that.
right,
And so I just was captivated by the
yeah,
idea. Their plan is to take an old school that's on a location that overlooks the Hudson River. So it has some dorms because it was a school for juvenile delinquent kids who needed a lot of supervision. So
yep,
while these aren't juvenile delinquents, they do need a lot of supervision. And the
mhm,
idea of having kind of group type dorms with central areas is very appealing. So they have
mhm,
the homeliness of a central living room, so to speak, and then kind of like a college campus, they will
yeah,
go to a dining hall to eat, and there'll be plenty of good food for them, and plenty of support and love and consideration. And they plan to have a hotel and other industry on the campus. The hotel, so family members could come and visit.
right, right,
Grandma could come and visit, and their aunts and uncles, and they would be able to have some types of sheltered workshop where they could have
mhm,
industry and be productive, and lots of other activities. And it's a very large campus, like 500 acres. The thing is gigantic, and it's very beautiful.
uh-huh,
It's an hour and a half from Manhattan. So if you look at that's sort of the center of the metro area. So if you were to be, say, 3 hours, you could be in Boston, you could be at the end of Long Island, and you could be at the bottom of New Jersey. So that is a gigantic population. And when you look at the incidence of autism, this would be the first of probably many facilities in this model, especially if they're able to generate the kind of results that I think they're going to.
yeah, I agree. I think that that we're asking parents and individuals to make choices between a rock and a hard place. There's really no adequate long-term solution to people that have these challenges, that they're not able to be independent, but yet they're not able, but they're not useless. They're not,
Right.
don't need to be shuffled off to somewhere where they're, meeting them where they're at. I guess that's kind of what I got from Adriana, is everybody can do something, and, what can we do to facilitate what they can do and focus on abilities, but not overlooking the physical and medical challenges that many in this population have. So yeah, you put it really well with your description of the project. I know she
That's what I
is.
got out of it. And
Yeah,
so I wanted to be part of that. And
yep,
so I tried to help them. I'm very busy trying to do what
I
I
gather.
do. And so I'm not able to, be actively engaged in any of the operations. So a board level position is appropriate to be able to help out. And
Hmm.
I do have a lot of connections and to help out with that a little bit. And I'm just really interested in it. So I volunteer on that. It's one of the things that I'm volunteering on. And I hope we'll be able to secure the needed funding to get it off the ground. My guess is that it's going to take off very rapidly once that happens. And I think the results are going to be really outstanding. And I think it'll become a model that will be replicated in lots of areas, around lots of metro areas where there
I
is.
agree.
So
It's
I
needed.
think, and I think Adriana, since it's, you know, it's very close to her, she has a child, Nicky, who
Mhm.
needs to have a plan. And but how about that? Someone who's willing to devote their life to finding that plan and to make that happen for their child and for the children of many other people.
Yep. Yeah, I had her on the podcast about a year ago as a guest and was just blown away, you know, and then ended up meeting her person, going and meeting Tom and Chris, and kind of slowly getting involved in helping with their social media a little bit and doing what I can. But yeah, just really inspired by all of the people that are involved in that. So, and you know, the people that she is connected with on the board, this is the first interview I've done with a board member. I hope to do other interviews, but she's spoken very highly of you and all the, you know, Chris and Tom and all the knowledge you have about coming from the IT approach as opposed to, you know, like you said, coming up in the, you know, traditional sense of healthcare, but kind of being outside the box and questioning these processes and procedures. Really.
Yeah. Well, that is.
Yeah.
I don't know. I get to, you know, Steve's most excellent adventure here, and this is a piece of it, and I'm just really glad to be part of it with them. I think that they're going to make a difference, and that's important to me, is to make a difference.
Thanks, Steve. I appreciate. Yeah. Thanks for sharing what you did about your, you know, your grandfather and how that was a real pivotal part of your journey. Yeah, that I love hearing that part because it
yeah,
seems
it's you know, we get to go through life. We only get to take the trip once, so we should make the most of it.
totally
And
agree.
I turned around a small bankrupt hospital and took it from like worst to, I don't know, worst to first, but you know, pretty far up there, enough so that we are recognized for our leadership and commitment to quality and outcomes and patient satisfaction and financial performance. And by every metric, we have to excel. And I'm captivated by Nicky's Garden, because I think with a little funding and a little bit of time, they will figure out what it is that makes outcomes improve. Let me give you one last example of something that I did that I think is the kind of thing that I'll be able to help them with, because I'm also sort of operationally driven. So I went down and one of the core services that small critical access hospitals have is we provide subacute rehab for patients that have been in our hospital or other hospitals as an acute patient, maybe a stroke or a major joint replacement.
Okay.
They're no longer critically ill. They're no longer acutely ill, which is less than critically ill. They are now subacutely ill, and they're just not able to go home because they're not strong enough. They've been debilitated for a long time. They tend to be disproportionately older folks that take longer to heal. They just don't bounce back as fast.
Right.
And they may have spouses who aren't really able to lift them up and care for them. So
Okay.
they come to our facility for a couple weeks, 2 to 3 weeks, and we have very robust therapy and nursing to help get them up and around and build up their strength and then get them home.
Mm-hmm.
And one of the dirty little secrets is that if you fail rehab, you get placed in a nursing home for the rest of your life. And I have yet to meet the first person whose goal in life is to end up in a nursing home for the rest of their life.
That's daunting.
And so my goal is to get as many people home as I possibly can, because that's what they want. And so I went down, I talked to my nurses and my therapists, and I said, listen, I want you to come up with a measurement tool to measure the functional outcomes of our patients and then I want you to improve them. And I think I would have had better luck using a paper wasp's nest for a piñata. They were so angry. What seemed to me was perfectly normal. We would measure it and make it better like we did everything else around here. And they said, we're already getting the best outcomes that we could have. And our patient satisfaction is through the roof because we measure that, so we know it's good. And we also know it's good because they keep bringing us baked goods, cookies, pies, cakes,
Really?
and wonderful cards telling us how happy they are. And we're working as hard as we can. Why can't you be happy when things are as good as they could be?
Yeah.
Yeah, I'm not really a happy guy. I made them do it anyway. So they came back to me after they selected a tool, after they ran it for 6 months, and they showed me the data. And I said, well, that's, pretty good, but why can't you make it a little better? And they said, well, you see, Mr. Kelley, that means when they say Mr. Kelley, you know that's bad.
Pretty.
It's Steve, it's, we're collegial, we're friends, and they agree with me. It's when it's Mr. Kelley, it means headed in the, they said, the only thing that protects us is something called the standard of care. So if somebody has a bad outcome, then we get sued, or we may get sued. If we do get sued, the only thing that protects us and our licenses is the standard of care. And if you follow the standard of care, we don't have to have good outcomes. That's what we guarantee, is that we're going to follow the standard of care, not that you're going to be guaranteed any outcome, because we don't really know. Sometimes people get better and sometimes they don't. And I said, I think the standard of care is the floor. That's what is the minimum expectation. I am reaching for the ceiling. I am not interested in being a bottom dweller. So let's get that out of the way. I'm not talking about doing anything that's going to lower us below that standard of care. We should be teeing off from that. That is the foundation. Now that we got that out of the way, I believe that the 80-20 rule applies to just about everything. And that 20% of what you do is generating 80% of the results. And I want you to figure out what that is and do a little bit more of that. That's all I want you to do. We're not changing anything that you're doing, except you're going to do a little bit more of the 20% that generates most of the benefit. Well, nobody ever thinks about it like that. They are trained to do it this way. This is the way it's always been done. This is the best way. If there was a better way, we'd already be doing it that way.
Yeah.
But then when you challenge them and cause them to rethink, well, what is it that, they started looking at gait training, they started looking at a few other things.
Okay.
And then they started experimenting with it, and the outcomes got better. And a year later, we went and looked at those same metrics, and they had improved functional strength metrics, and our patients had improved by 16%. Wow. In 1 year, 16%. Wow. That's gigantic. And so what happened was our return to home rate went from 79% to 90%. So if we had 100 patients, that meant that 11 more patients avoided going to a nursing home.
That's great.
And when somebody goes to a nursing home for the rest of their life, you know how it gets paid for? It gets paid for by them first. So if they have a bank account, boom, zeroed out. If they have a house, sold on the block. They own a car and all their possessions are all gone. And when it's down to $4,000 about, which is what it costs to bury them, then Medicaid takes over, and people complain, our taxes are pretty high and we have to pay for all this Medicaid. Well, that's a big chunk of what you're paying for. And if we can avoid that and get people home, then guess what? Their children may have a little bit of an inheritance, and they may have some money to help their grandchildren go to college.
Yep.
And they don't have to be in a nursing home for the rest of their life.
Yeah.
I mean, think about that. So I presented that at a critical access hospital meeting. We meet quarterly here in New York, all the 18 hospitals. And I asked the other hospitals to join us with this, to try this and see if the protocols would work and see if we could improve outcomes across the state. And I got the health department to engage Stroudwater Associates, which is a very notable consulting firm based up in Portland, Maine. And they never thought about this before, but they were very interested in it, and they ran all the analytics. And guess what? Outcomes improved across the state. It was pretty amazing. And then fast forward a few years, and the University of Minnesota got a contract to measure this product in critical access hospitals, and to compare it to other alternatives. And Stroudwater Associates did a lot of the analytics for them, because now they're the national experts from what they learned from us here in New York.
Really? That's so cool.
Not very nice. They think of themselves as the national experts because their analytics are so great, and they just happen to be applying it to this, but they are very good.
Mm-hmm.
And so in the spring, and I think it was May, down in Atlanta, the University of Minnesota, Ira Moskovitz, he's the principal researcher on that, who's doing that work,
Mm-hmm.
invited us to join him to speak. And what was so interesting to look at his preliminary data from 200 and some hospitals from 16 states or something. I don't really like metrics. There's like the median line, so that's the average of the quality, and you can see all the dots around it above and below from the other hospitals. And then there's this little cluster that's up above the other group, and that's the New York cluster.
Is it? That's great.
So I think that Nicky's Garden will be able to measure the outcomes for their residents, and they'll be able to improve those lives, and they'll be able to quantify that over time.
Mm-hmm.
And I think that will be able to provide a very compelling story that will have lots of people want to replicate that and fund it and help support it.
Yeah. Yeah, I agree. It's a great story. I appreciate that. Yeah, hearing about everything. Really have learned a lot, and I appreciate your time, Steve.
Yeah, it's my pleasure, Jill.
Yeah. Do you have anything else that you want to discuss or promote at this point? Favorite restaurant, sports team, whatnot?
No. I'm just one of those people that just likes this, and this is what I do. You
enjoy it. It seems like.
I have a great job. I have wonderful opportunities to help people, and I like that.
I appreciate. Yeah, I love hearing about that. So positive.
Down to the end, it really comes down to one patient at a time.
One patient at a time.
One patient at a time. We have to make sure that everyone's experience is really good and better than they expect. And we haven't always done that in the area of autism, because we don't have a plan for people once they get past 22.
Right. It's kind of like nobody's even been able to take the time to think that far ahead and develop it. But we have people now that are doing that, like Adriana, and
there's others too. I don't want to say that she's the only one, but she's the one that I'm working with, and that I find to be so innovative and
oh, she's gangbusters.
She is. She's really great. And it doesn't diminish anyone else.
No.
This is the horse in the race that I decided to be with, and it's my hope that whatever small contribution I can make will help to make it better.
Well, thanks. I'm sure that you already are and will, and yeah, that's about it.
So is this helpful?
Very helpful. Thank you so much. I appreciate it. And yeah, we'll be in touch. I'll be in touch as we put it together, and look for your feedback. So
all right.
Thanks so much, Steve.
Take the rest of the day off.
I wish. All right. Take care.
All right. Bye-bye.
Bye-bye.